So here at Optima 2023, I'm Dr. Colin Hanratty from the Mater Private in Dublin, joined by my good friend and colleague Dr. Margaret McEntegart from Columbia in New York. So Margaret, we've just finished session 2, the calcium session, which you were largely responsible for. Could you give us your thoughts on it?
Yeah, so Colin, we kind of deliberately, rather than doing, the kind of traditional intravascular imaging, morphology type approach, we decided to focus this year a wee bit more on looking at the concept of mastery and how to develop your knowledge and skills, really to become an expert in complex PCI, and how the human factor aspect of the environmental situation that we have to work in every day can affect our decision making adversely. And we went through a 4-point decision making model from behavioural science to really discuss how in the cath lab there are things which in our kind of behavioural strategies and our cognitive biases that influence us to make adverse decisions and not make the right decision. And then we kind of went back to the technicalities and had a really kind of comprehensive overview of calcified nodules, what we know about them, how to treat them, what we've learned really from detailed intravascular imaging and the use of all the different calcium modification devices to deal with those. So it was a kind of mixture of the kind of technical and then the kind of more human factor type approach to the session.
I think it was a bit more a move away from the technical stuff, wasn't it? In previous years we've spent time showing you how to do rotablation, how to use shockwave, how to use cutting balloons and the technical aspects. And these modalities are very good at managing calcium, but yet there's a wide range of what goes on day to day in the cath lab, and that's why I found the mastery concept so intriguing. What do you think is the biggest learning point there, or what do you take from it yourself?
Yeah, I think that we have got very focused on the technicality in recent years because of the explosion of devices and because of the kind of upsurge in imaging. And I think it's time now for us to kind of step back, I suppose, and look at the bigger picture and look at the things in the lab every day, really influence the outcome of our cases, And I find that actually what's going on in the environment round about me during these cases is almost as important as the decisions I make about the technicality of the cases, So who are the team round about you? How experienced are they? How much of a hurry are you in? Are you under time pressure? Are you well slept? All these other things. Are you stressed for, you're concerned about the upfront risk of the patient? So I think it's really helpful now for us to kind of step back from just thinking about how to deal with the lesion and think more holistically how to deal with the situation in the patient.
And how do we enforce that, or how do we drive up standards? I loved your analogy at the end when you've done a bad result, but you want to get out there, so you talk it up, you big it up and say, doesn't that look good?
It's really interesting the overconfidence thing. I think, and we all do it, because we want to feel okay about what we did. We've all done that where we haven't used atherectomy or IVL and you've ended up with an underexpanded stent at the end and you can't get the MSA up safely, and you walk away and you persuade yourself it's going to be okay. And actually what we really need to do in that situation is to kind of reflect on the fact we did make a wrong decision and not do that again, so learn from it. And I think we have to continually question ourselves and question what we do and continually strive to do better.
And I wonder if we sort of should be applying guidelines as to what constitutes a good result, what is the minimal stent area at the end of the case, applying criteria. Is that the way forward in this?
Yeah, but I think also, again, looking at kind of the bigger picture. So Simon's talk was interesting in that you take two lesions that look the same but two completely different patients. So you get a young patient with no risks apart from the lesion, and you get an older patient with all these other risks, poor LV, peripheral vascular disease, CKD, same lesion, much different risk, kind of overall risk in those two patients, and how you're going to approach those two patients should be different. So in the younger patient without risk factors out with the lesion, you're going to really focus on making a great result in that lesion. But in the other patient, you're going to focus on a much more holistic assessment of risk, and maybe you're going to accept a lower MSA and not perforate the vessel and not give the patient acute kidney injury or put the patient on MCS. So it's all about this kind of trying to balance up the pros and cons of the different strategies and different types of patients, and we haven't really explored that much before in the past. I think that's really where we should be focusing our efforts.
And then of course we have a fantastic talk from Ziad on nodular calcium.
Yeah.
Do you want to give us a brief summary of that?
Yeah, so I think this has been one of the areas in the last kind of couple of years where we've really learned a lot, and it's really been driven by the upsurge in imaging use and obviously also the available of IVL. And this concept, we've always thought that when we perform atherectomy, we're really reducing the volume of the calcium, but it looks like we probably only reduce the volume out somewhere between maybe 10, if you're lucky, 15, 20%, and that you're actually often going to have to do something else to that nodule. And use some kind of modifying balloon technology, be that IVL, a cutting balloon, a scoring balloon, to try and then deal with the rest of the calcium, in the base of the mountain, I suppose. So that was quite an interesting thing to reflect on. And then also this evolved concept that Hina Kiko Mahara have come up with about the fact we have these eruptive nodules and then these non-eruptive nodules. The eruptive nodules being much easier to shatter, much more associated with end STEMIs, but much more likely to recur.
Yeah.
Whereas the non-eruptive ones be much more difficult to modify, but much less likely to come back if you do a good result up front. So I think it's a really interesting perspective to give people to go back into the lab and start to look for these features in their imaging.
I think the imaging underpins it all, doesn't it? And it's not one size fits all.
Yeah.
And I think you need multiple modalities to modify calcium now, and they're complementary, of course, aren't they?
Yeah, I think that's right. And I think the initial, when we started to get an explosion of the calcium modification devices, it was this, which one's going to win?
Yeah.
That's kind of gone away because we all realise they all have benefit in different circumstances, either in isolation or in combination. And I think that's the thing we're working through now, is in what situation is that combination better, and can we figure out from our imaging what we should be choosing, one or other or combinations of the two. And I think that's the next thing we're looking for, I think, in algorithms and guidelines going forward.
One of the things about the algorithm this year was so much less complicated than previous algorithms, and it's almost back to there are balloon modalities and there are debulking modalities,
Yes.
and just separating those two, I think, has been very, very good.
I think so. I think that's because I think we got really into the kind of morphological detail, and I think we needed to do that to evolve our thinking. But I think now we've evolved our thinking to where we are. We can actually kind of make things a bit more simpler.
And more pragmatic.
Yeah, more pragmatic.